Hi, I'm Gilly Bond, a specialist pelvic health physio, and I'm answering your questions about bladder pain syndrome. What is the difference between interstitial cystitis and bladder pain syndrome? Okay, so interstitial cystitis is the traditional term for the feeling of having pain in your bladder, needing to go all the time. It's described as feeling like a chronic urinary infection, so urinary tract infection that's gone on for too long. And it was the term used way back when they had no idea what was going on and they thought, right, it is just a chronic infection. And in some cases we know that embedded infections do exist in the bladder, but they're not necessarily the be-all and end-all, and actually they're a small part of what happens in the whole problem, the whole condition. So interstitial cystitis are words that mean a cystitis, an itis, an inflammation of the cyst. So bladder in medical parlance is a cyst. So cystectomy is a bladder removal. Cystoscopy is an oscopy, looking a camera into the bladder. So it's an itis of the bladder's interstitium, which is the lining of the bladder. Now, that's a really poor term for now what we do understand about what's going on in this condition, and so we don't use it anymore. So interstitial cystitis as a term we've moved away from that term in the UK and definitely within the EU over the last 10 to 15 years, because we understand more that actually it's not just about the bladder. It's about the pelvic floor, it's about how your other organs interact, it's about the visceral nerves downstairs, so the nerves that go between the organs. It's also a lot to do with how your brain perceives the threat, what's going on with your bladder. So we also moved away because we know a lot of people with bladder pain syndrome won't have true symptoms in their bladder lining. And actually the evidence shows that we find symptoms in people that don't have pain. So there used to be a school of thought where interstitial cystitis is where someone has what we call Hunner's ulcers or glomerations, I can never say it, which are two types of kind of small issues in the lining of the bladder. One is like an ulcer, like you get in your tummy or anywhere else that you get ulcers on your tongue or breakage in the skin. And the glomerations are small, tiny little areas, both of which would bleed when you put water into the bladder. So they show up quite easily when we do a cystoscopy. Now, there's lots of evidence to suggest, because they've done lots and lots of research into looking at everyone's bladders, that we find these kind of lesions in the bladders of people that don't have any pain. So if we're finding them in people that have no symptoms, do we think that these issues with the bladder lining are what is causing the symptoms in people with bladder pain? And the answer is no. We can't guarantee that's what's going on. In some people, it may be, and that's why we try and help those people by giving them installations to the bladder to line the bladder to make it feel a bit more comfortable. But we can't guarantee that that's what's going on, because like everywhere else, we find lesions in our body all over the place that have nothing to do with how we're feeling. For example, a really common one that we use all the time as an example in physio is disc bulges. So when someone slips a disc can't slip anywhere, they just kind of bulge a bit. But it's really blooming painful. But we know that a large quantity of people are walking around at any one time with slipped discs and no issues. So if you are in your 40s, then 40% of the people in their 40s will have slipped discs and no symptoms, no pain. That's because the body is very good at coping with changes in our anatomy, and if it's not particularly threatening, it's not structural, it's not a real big issue, then it's not going to respond to it with perceived threat if we're coping well. And certainly from a slipped disc perspective, if we, in physio, we will calm down those discs. We will get someone moving, calm down all the secondary issues where all the muscles have gone into spasm, but we won't necessarily try and do things to the discs. And if anyone tells you they're trying to, they're fibbing, or they're not understanding what they're doing. And then people get better and their pain gets better. And yes, sometimes people have to have operations, but the vast majority of people get loads better from their disc issue and go back to their business and go back to running, doing triathlons, doing Ironman, loads of stuff. But the disc bulge never changes, and it's still there. Or it might reduce a little bit. And in some cases it does go away completely. But the point is that we don't necessarily have pain from structural issues. Pain is much more complex and beautiful beast. So in interstitial cystitis, calling a condition, basing it on something that we're not really sure is causing it, is not the best way forward. So we moved away and we called it bladder pain syndrome. And that means that we can encompass everyone that is having similar symptoms, but as a spectrum of disorders. And those symptoms are, it gets painful, you have pain in the bladder that's lasted for 6 months, and it could be pelvic pain anywhere. So it could be pain between your legs, it could be pain in your hip, it could be pain in your back, pain at the front of the pelvis, but commonly it's round about up above your pubic bone in the kind of bladder region, or between your legs in kind of what some people call the gooch or the perineum. It can involve the front of the genitalia, it can involve anywhere in the genitalia, testicular pain, vulval pain. But pelvic pain that's lasted for longer than 6 months. It gets worse when your bladder fills, when you need a wee, and briefly or quite a long time, however much, resolves a little bit when you empty your bladder. And it makes you feel like you need to go more often and that you are more urgent when you do go. So you really got to get there quickly. Those are the 3 main criteria based on loads and loads of different governing bodies that decide that how we're going to define it. The 4th criteria is with or without infection. Because we know some people have got embedded infections, they're not so much of an issue, and watch my video on embedded infections if you want to know more about that. But they are sometimes a bit of an issue, so we've kind of got that on as a number 4 definition, but we don't really mind what's happening there. The key is you've got those 3 things. So we've got this new term, bladder pain syndrome, because it encompasses a lot more about what we understand of modern pain science and all the research that's gone into understanding this condition. Confusingly, for whatever reason, and I don't quite understand why, recently the British Medical Association, the BMJ, published 2 subclassifications. So there's bladder pain syndrome, which is all of those things that I've just talked about, and they've subclassified interstitial cystitis as all of those things, and then someone that has Hanna's ulcers or glomerulations on assessment. And I'm not really sure why they've done that, and it's given a lot more, it's made everything a bit misty. We don't have clarity. And as an international group, we really want and need clarity in how we define and how we talk about this condition, because so many people are misdiagnosed. Regularly when I teach, people come on the Happy Bladder course, my physio colleagues come on the Happy Bladder course, and they say, I don't see many IC BPS patients. And I say, actually, you see all of them, because these are the people that are diagnosed with vulvodynia that have some urgency, so pain in the outside but some urgency. These are people diagnosed with testicular pain and back pain that also have some urgency, or it gets better when they relieve their bladder. So we have huge amounts of misdiagnosis, so it's really important that we talk about the same thing. And that thing needs to be bladder pain syndrome in the UK, so that we can search it in our mesh terms when we're researching, and we can talk about it under the same umbrella. If research comes forward proving that actually Hanna's ulcers and glomerulations are actually a big thing, I'll revise my ideas. Fine, I'm research and evidence based. But at the moment, I'm still not particularly happy that we define it by structural issues when we know that pain has very little to do with anatomy. And dysfunction is based on threat, which is pain. So I have issues with that, but hopefully that's kind of clarified. In the US, they still use IC as a definition in lots of places, but the main kind of World Congress of Abdominal Pelvic Pain that we've had with IASP and IPPS, we have moved towards calling it bladder pain syndrome, and certainly the international conferences I've been at, we all call it bladder pain syndrome. It also shouldn't be painful bladder syndrome, which is what we tried to call it for a while. If you're reading any papers, you might see them IC/bladder pain syndrome, and that's just because while we're in this period of transition and trying to change how we talk about it, change how we understand it, we need to make sure we catch everyone that's writing about it. So we're all trying to write IC/BPS and move towards trying to talk about just BPS. So I hope that's made it a bit more clear about what's going on at the moment, and obviously I'll update this